So what I do is that I try to kind of say mix and match and connect a flow to understand why there is a need for us to look into healthcare industry from say pharmacist perspective. Okay? Then let's see what is this called medication management, medication management plan in the healthcare system. Essentially, when we say medication and the error, it need not be only a drug. There are a lot of other events in and around that leads to a lot of complication which cost a life. So I really want to focus on medication error, which is the core part of the medication management plan, and how do you fit in that system, and how the healthcare system works around that. Okay? Define a protocol. Okay? In the interest of just time, I just try to connect some key areas, but there are a lot of things which I personally feel probably you can learn those through some workshops or some other mode of learning like the conferences. Okay? Right. So, why do we need medication management? First question. We know that now there is a good doctor, we have a lot of AIs, we have a lot of advanced diagnostic tools. We can get an X-ray, we can get an MRI, we can diagnose what person is having. But where do we fail? Finally, it's the medication which actually need to work at the individual patient level, and there should be a precision in that, and that's how the healthcare actually be effective. You know that in the current world, it's a very busy world. A physician will be visiting multiple hospitals, will be taking care of multiple patients in a day. So definitely he or she don't have much time to pay personal time. See a lot of new therapeutic products being okay, so new therapeutic products are getting added to the market. So me drugs are a big in number. We call it as generics. Add to that, people, medical reps and others are just here the physician to kind of increase their marketing strategies. Then we have another notion in the Indian scenario that like anything called Ayurveda is good for health. Okay, I don't know that. I don't want to comment on that. They say that there is no side effects. The question is that when there is no effect, then you cannot talk about side effects. Right? So to have a side effect, there should be an effect. It should act. Then when it is out of proportion, then you will have a side effect. So these all are contributing to the complexity of the healthcare. Finally, who is the victim? The patient. Understood? Okay. So just imagine this is old data. What I am seeing here is fine. So this is old data. It says that nearly 9,000 plus patients just died because of an error in medication process in a developed country like USA. Okay, just then think about what we can have in a country like India. Okay, so rough estimation around 2020, we say that nearly 5.2 medication errors have been reported in India. It's just a tip of the iceberg, but we don't trust this. The reason is that definitely there will be much more higher number than this. The reason is that we are so negligent of reporting those. Once we are done with the process, we just ignore and then we'll focus on something else. If it happened for me, if I report, probably that would have been recorded. Somebody should have got benefited. Right? So it's the same with the clinical trials. Why I should actually go and expose myself to a new drug when the well-defined or experimented drug is already available. But I just forget that what I am using as an effective drug was tested in someone earlier. If I participate when I am an eligible patient, so then definitely it is going to benefit for the next generation or someone who really need. So this mindset or attitudes towards the healthcare system is the key reason behind all this. Understood? It's all about the attitude we are talking about than anything else here, right? So, a lot of estimation in terms of pharmacoeconomics, we say that nearly 40 billion per year, approximately 40 billion is the cost of a simple medication errors. Imagine it's for just a few countries. Probably some lot of developing or underdeveloping countries probably might be having more say expenses over that. So all these are due to lack of this all say our attitude and the errors. What they are contributing is they are actually yeah, so finally what happens is that the trust between the patient and the healthcare system is slowly diluting. So now what we always say that if some doctor says that you need surgery, you think twice and you go for another doctor and you take a second opinion. This is all because of lack of trust, and we are not happy with the system how it is working. Even though you might have said that it's for your good cause, but still I think that probably this doctor is asking you to get the X-ray or ultrasound because they are into a commercial healthcare system. So lack of trust. So that's how the things have progressed till date. So my focus is mainly on the medication management plan, and the core of that is medication errors. So what are these medication errors? So what actually, as I mentioned earlier, medication error need not be related only to a drug. Anything in and out a medication is called medication error put together. It could be a drug in terms of wrong dose, wrong medication, wrong administration, wrong drug dispensed, or the drug which is not suitable for a right person has been prescribed. So medication error being a core of this medication management plan is something we want to focus. So what does this medication error being defined? The WHO and FDA defines any preventable event that may cause or lead to inappropriate medication use or which leads to a patient harm, while medication is the control of the prescribing team, that is NCP or consume that or any other consumers. Okay, so this medication error can happen across any of this process, right from the beginning of prescribing a drug till the patient who handles that drug. So these events may be related to professional practices or the healthcare products, the procedures which are involved in the prescription, and the system in and around that. It includes the prescription pattern, order, or any communication gaps, product labeling, packaging, or nomenclature, dispensing, administration, and patient education and monitoring. Okay. So we learned that what is medication error and its complications. Then what can we do to prevent these errors? The first question. When we know that there is error, what can we do to prevent these errors? Because the definition says any preventable events that lead to a medication error. So first and foremost is that in a management we always say what we don't measure we cannot manage. If you really want to manage something, first you should have a procedure to measure that. Then only you will be able to analyze and then take a solution for that. So to prevent those minimal preventable events called medication error, you really need a best organizational practice. So that's how we should, for example, in the context of the medication error, first within an hospital you should have a drug formulary. Okay, it has a list of all the medications, the dose, the generic name, okay, and the brand name, etc. So that the prescriber should be able to understand what he or she is prescribing, what he or she is dispensing to the correct patient. This is called drug formulary. So now we have different departments in our healthcare. Understood? So patient may not be affordable on OPD basis. So then we can have a separate formulary on OPD basis so that we can have more number of drugs. But an inpatient system is a very controlled system. So you can have a different formulary for patient. Again, ICU and emergencies are a very crucial, say, department within the healthcare. So they can have a different set of medications based on the efficiency of the drug and the requirements. So that's how a best organizational practice should always have an in-house drug formulary. Okay? So then you should have certain protocols and standard operating procedure which talks about how do you procure, how do you store, who should prescribe, who should dispense, how should be made available to the patient. What if something goes wrong? What is the procedure to be recalled and so on and so. This is called an SOPs or protocols across the department so that you can effectively handle those medications. So these are the measures, simple measures you take to prevent those preventable events called errors. Okay. So when patient get admitted, there is possibility of errors again at the patient level. So what we do is we have to take care of handling the self-medication. So your SOP should define how to handle those. Whether when someone is really looking at the medication chart, they should know how to reconcile. Mean to say that what is the medication history of the patient who came and what we are going to prescribe now. So how to now tally and ensure that there is no duplication of medications. This is called reconciliation. Similarly, whether any of the inpatients are having the over-the-counter drugs. Okay? And again, during the dispense, two different drugs may look same. We call it as look alike. Okay? When we pronounce, some of them make sound similar. They are called sound alike. So we put together, we call it as LASA. Okay? LASA. It's called look alike and sound alike drugs. So again, there are chances of medication error around these drugs. Similarly, there are certain class of drugs which are high risk. We need to be very careful. For example, fentanyl patch. Okay? There are chances of intoxication. So again, what is the defined treatment regimen for a given disease conditions? So all this information should go to a standard protocol, or we can call as SOP. Okay? So one organization at best, hospital always maintain these standard procedures. Similarly, to oversee these, the hospital will have something called drug and therapy committee, which will be led by an SME or called subject matter expert, preferably a clinical pharmacologist, who has a good understanding of what drug it is, what is the mechanism of action, why they should be prescribed, and that's how we should be able to understand the gap between the drug and the healthcare system. Then, if you have an auditing of the prescriptions done on daily basis and also the dispensing of drugs, administration of medications, if you do auditing on regular interval, you will get to learn the pattern of the drug handling. Understood? So by that you will be able to pick and see where there are chances of errors. Can you fix them? Okay? So these all will go into a defined SOPs and protocols. Okay? And to handle this, the healthcare system should have adequate resource and workload management and which also leads to a further error. So, an old system which includes pharmacists, healthcare, nursing, pharmacy team, they should be trained on regular intervals so that your management plan should define the training programs at a required interval. Okay? And add to this, one always the boosting or supporting system is technology. Okay? So whatever the best technology you bring in, the person who actually handles that should be proficient enough to use that and leverage the advantage of that. So put together, we call it as medication management plan or medication management usage tool. Understood? Okay. So we all talk about this, and this is a key pillar in the healthcare system which actually bridges the gap between a healthcare provider, which covers like a physician, nursing, pharmacy, pharmacist, and others, and the patient. Okay, so this is a big bridge which need to be filled. That's how the current fast-growing healthcare industry has a lot of vacancies, and this is one of the area where all of you can really think of seriously and look forward to pursue your career. This is a food for thought. I'm not forcing anybody. Okay? So think over that and see that you can still go work very close with a patient side and what is the satisfactory factor for you to contribute for the best patient outcome. I being in industry, I know what is called precision medicine. I work on nanotechnology. I work on very recent advances. Okay? But for me, what actually looking from a growing Indian perspective is the healthcare system, which actually require a trained resources from clinical pharmacist perspective. I felt probably this is one of the area you all could think if you are really interested to pursue your career in this. So that's the only objective behind this. Probably my topic might be out if you are expecting any pharmaceutical scientist background at this context. I'm sorry for that. Don't mistake me. Okay? So now, after understanding all those components of a plan, so let's define what is this MMP mean to say. MMP is mainly a structured patient-centric plan or a strategy. Okay? The key objective is to have an optimal medication use. Understood? So it includes medication reconciliation, do a risk-benefit evaluation, mean to say that when you prescribe a drug, there should be a rationale. Okay, and what is the effect, desired effect you are expecting, and what is the outcome, and then you tally. This is a risk-benefit evaluation. Then adherence support. Whatever the best drug I could say prescribe. If patient is not in a position to take that, or if he or she is not compliant, okay, then definitely your outcome is bad. Okay, so that adherence support is always important in this. And then you monitor and review. On any chronic conditions, you really need to monitor what drug has been prescribed, what dose we are giving, is there any chance for modification based on the outcome. So these sort of things are very, very key, essential part of the a good patient outcome. So overall, the goal of the MMP is to mainly align the individual patient goal for the care. Okay, so any idea what are these two symbols represent? You see a lot of this symbol, NABH. Any idea? Every hospital say we are NABH accredited, we are JSK accredited. Why they are placed now? Right? So if you are a very good student, bright student, what do you prefer? If you score first or second rank, you still prefer to go and work or say, means these are symbol of quality. Okay? So these are the certain non-particular organizations, they create certain guidelines to say, look, these are the way we can make the system best. So JCI stands for Joint Commission International. Okay? There are certain guidelines. Any organization per se across the globe, they can adopt those guidelines, set the standards, okay, audit it. If they meet the criteria, you get a certification. It means to say that you are meeting you are one among the best in the healthcare industry. So definitely you will be recognized from that perspective. Similarly, NABH. Understood? Okay. So when I worked in Apollo way back in 2011. We got audited for JCI. Okay, all Apollo hospitals are accredited for JCI. It's one of the international accreditation, right? So I was handling pharmacy department, being a clinical pharmacologist. Under me, there were nearly 14 clinical pharmacologists. So when I joined, you don't believe, for one or the other reasons, silly points, we ensure that we don't leave any scope for final errors. So whoever it is, whether it's the head of the department, whether it's a dean, if they are practicing, if they are prescribed, if there is an error, document. So that was our motto when we started. To begin with, including all the minor others things, we had nearly 650 medication error in a month. Okay, so in 3 months we brought it to 50 to ensure that the reason is that if you don't go back and say that you did a mistake, the person will continue to do it. So all these errors is just an attitude. It's not really mean to say that it's an ignorance, which is part of our thing. So we, as Indians, we are known for that. When you go to Singapore, you remove shoes, you walk on the lawn, saying that it's like my house. But when you come back, you still throw the tissue in the street. That's our mindset. Okay. So that's how we started. When we got JCI audited, it usually goes for 5 days, and medication safety is one of the core pillars. 2 guys will audit that exclusively. First day they did an audit. For first half a day, they didn't find any error. The guy came to me and he said that, oh, you are the head of the department. I said, yes. He said, how I am not able to find any error in your system? I said, sir, please continue. So end of the day, he didn't find any error. Then he challenged me. Tomorrow somehow I am going to catch you. Okay. The next day he came back with all enthusiasm and he asked me, okay, fine, tell me now, you have a formulary, right? You have a formulary for OPD, you have a formulary for IP, emergency and all those things. Now there is a drug which has been recalled by DCGI. Now, okay, so a patient has come to your OPD, he has been prescribed 30 days drug or say 2 months drug. Now patient has taken 60 days drug and he went home. Now drug has been recalled. Tell me, how are you going to ensure that that drug will not be taken by the patient? We thought well ahead of him. We maintain every patient's contact details so that we can call back them who take any medication more than 15 days. Understood? So then he realized that okay, these guys are not easy to deal. You don't believe the 5 days they say accreditation was called up in just 2.5 days. He said that one of the best audit I ever did, and he was a nephrologist from USA. Okay. So why I am telling this is that it's all our approach and attitude. If you really want to do, we should do it. Okay, otherwise we should not get into that mess. That's my principle. Okay. So coming to this MMP, my objective is mainly to fit yourself in the shoe of that role and see how you can really look for a career. If you really interested to contribute for the healthcare or patient care, if you really just want a job and have a happy life, go for other industry. Healthcare is something which is actually a satisfactory job. Okay, provided you are in the right place. So, as I said that being a pharmacologist, I was handling a team of clinical pharmacists. There were different, I had both bachelor's and masters, and even freshers from PhD who actually wanted to explore that opportunity and see how it works. So we ensured that we work across all the stations, starting from OPD till the emergency and even oncology preparations. Okay, so we had SOPs for that. So what does this clinical pharmacist does in a day-to-day healthcare system? They actually collaborate with the physicians, okay, and also other patient supporters, the nursing and pharmacy. It's a first core requirement for the pharmacist. So their objective is to ensure there is a safe prescribing of the medication, the dispensing happens without any errors, and they monitor. Understood? It's not just the taking care of the prescription and dispensing, but also to monitor. I mean to say that there are many patients who stay in the hospital for quite a longer duration. It might be 10 days, 15 days, sort of this thing. But you have to ensure that you repeatedly go to the same patient and see what was yesterday's prescription and what is today's, and what, say, how it is changing. That pattern gives you a lot of learning in terms of, say, patient care. So sometimes we change the dose, sometimes we change the route of administration, we change the formulations, sort of things. We need to understand why. Okay, so that is something very, very important. And you also act as an educator and advocate for patients. You get to see a lot of crazy patients at hospitals. I'll tell you frankly. During my first posting, I attended a patient who came, it's not a patient, during my forensic same posting, a patient who was brought dead and it was suicide, right? So he wrote a big suicide note saying that I am so and so, I am committing suicide. The reasons are, I am a hypertensive patient, I am a diabetic patient, I am a psychiatric patient, and also have hyperuricemia, means kidney stones and all those things. I am right now around 55. I have to take nearly 18 to 21 drugs per day. So dying this is much more easier than taking 20 drugs per day. Okay, just try to understand the human psychology behind when they are patients. Okay, so in these situations, I am one helping hand to counsel them, educate them, what is their condition, how lifestyle change can bring life back to them. So these are certain things actually matters a lot in our patient care, to be honest. It's not only a medication. So anyone who extend a helping hand, it could be anything, a nurse, a physiotherapist, a pharmacist, or a doctor, who can help, can extend their helping hand, really saves a life. Okay, so that's why a pharmacist can really play a role of educator and advocate. So that's one of the example, worst case scenario I'm telling you. So when a patient is there in the hospital for a long time, definitely it's a mental trauma for them. If they have to stay, they cannot move and all those things. But someone like a pharmacist who can spend 10 minutes time, who can explain what's going on, how best you can improvise yourself, what medications we are giving, why we are giving this really help them to understand and come out of the psychological trauma. So if you really want to get into this role, you really need to polish some of the skills, core skills I would say. First and foremost, you need to increase your clinical expertise knowledge in the medicinal product. Please understand, okay? That's a core. You need to know what drug it is, why it is being prescribed. A single drug will not be prescribed only for one indication. I mean, an antihypertensive need not be only given if his blood pressure is high. There could also be other indications because medicine is something always act by virtue of its mechanism, not by indication. Understand? Okay? So they need to upgrade their clinical expertise knowledge on the medicinal product and also the disease condition for which these drugs are prescribed. The rationale behind the prescriptions. And very, very important thing is communication and documentation skills. So we think that communication means to say that how good I am at English. No, it's not that. It's not called as a communication skill. It's just a language. Communication skill is something which always has certain empathy, okay, certain other factors. Means how good you are at communicating something to other person who can understand. Overcome the language barrier, overcome the knowledge barrier. So that is called communication skill. Okay, so you really need to work on the communication skills and similarly documentation skills. It means to say that it should be adequate first and foremost. It should be sufficient enough and detailed enough so that anyone who refers to that document should be able to gather information and process it further for the next action. This is called documentation skill. We call it as good documentation practice. Just like GCP, GLP, there is something called GDP. Okay? So you need to work on those. And once you have a very good logical and analytical mindset. Okay, for example, I'll say a patient was diabetic and he was operated for gangrene. Okay, diabetic food. Despite giving insulin and everything, the patient's blood glucose was not, was under control. Understood. But what we observed is that that fellow was so fond of sweet. Someone used to hide all the chocolates and everything and he used to sell, right? So one of my pharmacists observed that, sir, out of this bed we see ants. Okay, so you need to have a logical thinking of what why his blood sugar is not controlled despite giving insulin also. So then I asked the guy, he said, sir, anyone I'm going to die, but I want to enjoy what I really want to enjoy. Okay, so these sort of things are part and parcel of patient care. So your disease is different, but your pressure is different, and say way of living is different. So these sort of things, observation skills, and sort of things is very, very important. Then you also need to have analytical mindset. Analytical mindset means to say that when you have a piece of information, how do you really derive some decision-making steps out of those information? These are certain things you really need to work upon. So to be honest, once you pass out of the academic, unless you work on these skill sets, it would be difficult for you to go through and have a good professional career. Right. So now let's connect the dot and see what this pharmacist and a patient work together when they are in the sector. So in a nutshell, the pharmacist mainly works on the core component of the medication management plan. So that is your vital when you are in the healthcare sector. So what you do is that you always collect essential information, which could be a subjective and also an objective information about the patients. Okay. So for example, subject might be having multiple comorbid conditions, or he or she might be on many drugs. We call it as polypharmacy. So ensure that you collect all those information, and those informations are there in your medication chart, so that they should be able to understand why, what, when, how. Okay? So because our objective is mainly to have achieve a patient care, a faster recovery, an efficient outcome and all those things. It is possible only if you have adequate information. Okay? The pharmacist should work on understanding all those. So once you get that information, so you assess and analyze those information from the context of the patient for the given status or the condition. Okay? So how do you do that? You may not be able to do it alone. You always need to collaborate with the healthcare professionals. You can't substitute them. Okay? Because he is the key decision maker. Whatever you do is always value addition to the role. If you are able, because an healthcare profession as a physician could spare 5 minutes when you come for rounds, but you being a clinical pharmacist might spend a little bit more time to understand this condition. So anything you feel could bring a difference if you let the physician know, definitely it will be a big contribution for that. Right? So that's how you gain the confidence from the physician when you work closely. So down the line, they trust you. Okay, they understand what is the depth of knowledge you have about the medication, the disease condition. Then definitely they expect you to join them, and he or she can ask you that why don't you go and educate that patient? Why don't you revisit and see what is the dose given, sort of thing. So that's how you will always value addition to the team. Then in collaboration with the NCP, then you can help to develop an individualized centric plan to treat the given disease and the further outcomes here. Then you can implement those plans, then monitor. Monitoring in the healthcare is very crucial point, because we always deal with the chronic conditions. So you need to follow up and understand the pattern of medication, the disease progression, modification, and then the outcome. So to do that, what will be my day in, day out as a clinical pharmacist? Okay, so as I mentioned, as for the JCCI, mainly JCI, I don't know much about NMBH because I don't have hands-on experience with the NMBH. But both talk the same language but in a different intensity. That's my understanding. Okay, so what we used to do, my clinical pharmacist team was always on the floor. Okay, from day till the evening. Do a regular visit to the wards, then go through the medication records, then audit the prescription data. Okay, then look for the medical and medication history and do a reconciliation. What was his medication till yesterday? After admission, what are the current medications? Is there a change? Is there any duplication? Is there any change in the dose formulation, etc.? This is the first step, right? Okay, so this will be a routine. Not only the wards, you also audit the nursing stations because they are the main caretakers, and you ensure that they are doing a correct dispensing. Whatever they have at the nursing station is adapted up to the mark. It is possible that some of the quick accessible drugs might be at the nursing station. For example, paracetamol or some other emergency medications. So it is possible that under the workload and pressure, these nursing people can ignore sometimes. So you ensure that whatever the dispensaries or the medications they have at the station are not near the expiry. So our MLP clearly defines when to take out the medication from the entire system. It's not till the last day. I define at least 3 months before the expiry date so that I can minimize the error. Okay, so that's how MLP is very stringent guideline, and that's how we all work around that. Then you go and audit the pharmacy. The best thing what we do in the pharmacy is just observe what they are dispensing against the work order. The prescription order. Then you will get to see what may happen is that a pharmacy guy may be delivering the medications regularly to the same patient for a given ward. First day, for example, you take a patient who has undergone surgery. First day, you will be given ringer lactate because we want to have some sort of say balancing out the acidity and other things. Second day, patient will switch the ringer lactate to normal saline. That is 0.9% sodium chloride. Third day, they will switch over to 0.45 because now they want to taper that drug. The pharmacy guy or the delivery guy, they blindly act sometimes. They keep on delivering the ringer lactate for all the 3 days. Got it? So this is complete a dispensing error. So you being a clinical pharmacist, stand there and watch what they are dispensing and what was the medication error. What was the order. So now you are able to pick. It's just an attitude of the person and the ignorance which is leading to the errors. Understood? So do you think that you are contributing for the patient care in this way? Definitely. You are preventing a major error. Imagine it is a very serious drug. If something goes wrong. For example, if maybe has been prescribed antibiotic serum. Okay, but the patient dispenses an injectable antibiotic. Imagine the consequences. I'm just giving an example. Okay, so even a simple watch, simple contribution is a valuation for the patient care. Okay, so you have all the patients and you know the system, how it acts and how it should work. That's how your role is a value addition. So then you report whatever the observations you make. You are doing the audit for the ward, then the nursing station, the dispensing from the pharmacy, or if you find any expired drugs and all those things. Then you maintain the audit logs. As I earlier mentioned, what you don't measure, you cannot manage. So you need to have some data to say we are doing a proper work. If you come across any typical incidents, use that as a case study to educate the overall system. Okay, so nobody in the healthcare has sufficient time to go back and learn from the mistakes, but still we can be a value addition to that. Then, based on all your observation, you still have a good chance to train the nursing and pharmacy team about the medication error. Then, what are the preventive measures? Okay, so this is the overall cuts which I actually want to kind of highlight in terms of role of clinical pharmacist and the management plan is one of the Bible on which we all work in the healthcare system. That's how we work mainly towards the patient care. Since I mentioned medication error is one of the key component of the event, I'll just touch upon just for the knowledge sake. Okay, so this medication error is not the recent one, it is there for ages. When it has been first learned way back in 1970s, the Western people they started thinking of how to we prevent those. Then they started forming a lot of committees and regulatory bodies. That's how this medication error, post which this medication management plan, then the accreditation, the quality, everything came into place. It's not the new one. It's like it's almost 5 to 6 decades old. Some of these bodies, they work very late on this and they make the guidelines. They say medication error need not be only from the medication perspective, it also from other activities in and out of handling the medications. It could be again from a compromised dosage, that's the source of the error, or it could be a prescription error, or the system who handle the medication if it fails. Okay? So all these are the key contributions for them. That's how they classify it. So these are some of the highlights of the types of medication error. And this graph is just understanding that how each error could contribute to the overall medication error. See here in this graph we could see just 26% of error is mainly from the omission error. When we do audit, we see the same. They write the drug, but they don't mention whether it's a cap or tablet. Okay, they may write tab XYZ, they may not write the dose. If they write the dose, they do not mention the unit, whether it's mg, microgram, whatever it is. So these omissions will lead to a lot of errors. It's a simple thing. Either NCP, a physician might be negligent, or he may not be having the knowledge, or something should be wrong with the system. So we see 26% of omission errors. Similarly, the improper dosage, another major contribution, put together 50% contribution. Okay. Then unauthorized drugs getting into the system without the knowledge is another major challenge. Then comes the prescription error, the wrong timing of drug, then giving an extra dose, so on, so on, so on. So all this comes under the medication error. So in the crux, medication error is a very broad topic and key pillar of medication management. Right. So what are the reasons for medication error? So after knowing all this, some of these organizations try to classify them and group them to understand what are the key factors contributing for them. So they classified those factors into factors concerned with the NCP. NCP is healthcare provider, that's a physician, nurse, and so on and so on. See, if anyone is new to the system, so less knowledge or lack of knowledge is one of the major contributions. Then lack of training, illegible writing, inadequate perception about the risk to the patient. For example, if subject has a say stage 1 or stage 2 renal failure, so you need to be aware that what drug I am giving and what should be the dose in those conditions. So when we ignore those, it's a risk to the patient. Then you know that workload is one of the key contributing factors. Nowadays, it may happen with the physician, it may happen with the pharmacist, or even with the nursing one. And lack of communication or poor communication between the HCPs, it's across again to the patients. If I just prescribe but I don't say, for example, if I prescribe OMS, if I don't say this drug should be taken 10 minutes before the food, then definitely it will lead to an error. So patient will believe all the drugs should be taken after the food. Another error. Okay. Similarly, antidiabetic drug, oral antidiabetic drug should be taken at least few minutes before the food, so that it will prepare your body for the next insulin action. So these poor communication between the HCP and the patient is the key contribution for the errors. That's how a clinical pharmacist should be an educator in these gaps. Okay. So other contributing factors are again, as I said, it's the workload and the time pressure. And you see that a lot of hospitals do not follow the protocols. Now it has become a business. So that's a different story. Okay. So then lack of standardized protocols, again the medicine part. So I'll take a few minutes. So when it comes to prescription error, the clinical pharmacist will definitely act as a bridging person in this gap. The key objective of every person in this scenario is to ensure there is a rational, appropriate and effective prescription of the drug. So the simple way is you ask these questions, you should be able to get the answer. Is this indication adequate for this drug? what is the effectiveness you want to achieve, what is the disease condition, what are similar drugs which get into the system, is there any possibility of interaction, dosage, order, and what is the cost of the drug. Okay. So dispensing error, as I said, that one of the thing is that one is illegible handwriting or incomplete knowledge about the drug, look-alike and sound-alike, say, drugs. So NMP is the best protocol or the document which can address all this, put together and educate the overall healthcare providers, where you can really contribute in those SOPs. Okay. So again, when it comes to administration error, this happens between the nursing and the patient. So again, it's another different vertical where you can really work as a value addition. You audit the overall prescription, the administration details. If you come across anything, you report them and then retrain them. That's the value addition. Okay. So, right. So in nutshell, when we say we have achieved a quality, we have to ensure that the process is in place. Understood? So the provision of drug therapy by healthcare provider, whether it's physician, nursing, pharmacist, to the patient has become a complex process in the current environment. Okay, so that's how this medication management plan is becoming one of the cornerstones in the patient safety for the patient outcome. You being a clinical pharmacist, definitely a key value addition person where you can partner and can help to optimize the therapy and the outcomes. So what you really focus here is you have to collaborate with those people, then educate the team which get involved in the healthcare, whether it's physician, pharmacist, and including the patients, and then find a way to bring best practices. That's an innovative way. So all together, you will go to achieve the patient-centered care. That's the objective of today's the talk. So I would like to conclude this session saying that quality is always a kind of a workmanship. Means, why some of the best products are existing in this world is always because of their attitude towards that. So I believe the word quality is not just by virtue of it. I don't say it's a product as a quality. It's always about our attitude towards achieving that. So in our work, I say we are doing our best towards the patient care. It's all our attitude. So I believe this session will give you some input. You could think over that. If you are really interested in healthcare and the healthcare industry is growing faster, think ahead, prepare yourself. Have a nice career. Thank you.
Thank you, sir, for your informative and educative session on medication management plan in patient care from pharmacist perspective. Take this opportunity to ask questions, discuss and interact with our expert.
Sir, it was a good presentation, but I have a question for you. We are talking about auditing prescription. When a clinical pharmacist audits the prescription, if they found that there is a drug interaction or the dosage is more, what would be your reaction on it? Yeah.
So first and foremost is to understand the mechanism behind the drugs. Okay. So what is the reason behind the drug interaction? Whether it's the nature of the drugs leading to drug interaction or the timing of administration. Okay. You need to understand all those. So now the drug interaction is a generic term. Okay. So it's possible that one drug can suppress the action of other drugs so that your disease may not be effective, or that one drug can increase the action of the other drug through examining system, so you will see the side effects of that. So once you do the analysis, now you do the patient condition. What is the essentiality of either of those drugs? Okay. drug, or you have to let go one of the drug. So this is the approach.
What happened to the dosage of that drug? Suppose you have prescribed 500 mg,
Yeah.
but 500 mg pharmacist says that it is more.
Okay.
Then how will you react for that with the blood?
Yes, sir. See, now if I prescribe 500 mg to a patient, first and foremost I need to analyze the essentiality of that dose. Okay. So do I really need the 500 mg to achieve the efficacy in this patient? That's the first question. If there is scope for me to reduce it to 50, then definitely I will go, but not at the compromising of the efficacy of drugs. 250 may not be effective in this patient, but if I force to prescribe 250 and I'm not achieving the desired effect, then it's up to me for me to even adjust 250. Okay, so I need to evaluate the overall context, the essentiality of the drug. If I really need 500 mg, let other drug go off because I need this drug as a primary treatment module. Then you look at substitute for other drug or vice versa. Either.
Thank you. Yes.
Thank you for your presentation. I want to ask just one thing. Like in your medication errors, there is chances of illegible handwriting, and this is a very common problem. Every doctors write
That is the signature style.
yes,
That's all you recognize there.
yes. So actually, as a pharmacist, as a scientist, we read the GDP principles and law principles where legibility is most prime importance.
True.
So why regulations cannot be implemented in this sector to improve patient acceptability and confidence?
Right. So there are two things here. It's not only what I say. It's wherever the people are involved, it's difficult to change. So that's how physician being a dominant person here, it's difficult to change. So the best way is what we do in MMP is that there is no handwritten prescription under JCI. It's very clear. You have to go and enter everything in the system. You ask, you take a help of an assistant to kind of print it out, cross check and then send it. That's the one way to eradicate. Or the best practice, you write all the in the capital so that you have minimal chances for accuracy. See, sometimes what may happen, I can be mistaken with the health if it is in the small letter. Okay? If it is in the capital letter, it's possible that you can at least something that is better than this. So this is the one way I would say. Or it's again, it's all attitude. As I say, if a physician or any healthcare provider, if he or she is really concerned for the outcome, if they really have good intent, then if they understand that okay, my illegal handwriting is a major problem behind all the outcomes, he or she should correct themselves. If they don't change the mindset, it's up to you. Thank you. Well,
I request delegates to clarify their doubts with our experts.
Yes, sir. My one doubt is how already the patients taking so many medications, how the body drug is resistance, how we can find?
drug resistance is a genetic term. So drug resistance matter in certain scenarios. So for example, if subject is having a different infection, we just go to the pharmacy and take whatever antibiotics he or she wants, or it has been given just over the counter by the pharmacist. So over a period of time, they will develop a resistance to that
ಒಂದೊಂದು
particular
ಇದ್ರಲ್ಲಿ ಕೊಟ್ಬಿಟ್ಟು ಬಂದ್ವಿ
Okay, that's the first
I'm
part.
out ಬರಲ್ಲ ಮೇಡಮ್
Second
ಜಾಸ್ತಿನ
part,
ಡೇಟ್ ಕೊಡ್ತೀರಾ
the prescriber also need to analyze what is the essentiality of those drugs. For example, if you come to me with a common cold, now I need to analyze why you have common cold and what is the cause for your common cold. I should not directly jump and prescribe you an antibiotic. Common cold could also be caused by the viral infection, 99%. Okay, unless there is any compromised immunity look for the rationale of the prescription. So if you still continue to have infection after the fifth day, there is certain investigation I could go for, then analyze and look for the rational prescription within you. So these are some of the procedures we could maintain. So resistance from other drug perspective has a different mechanism. For example, in a cancer condition, if I give a particular chemotherapy or any other drug, the disease will recur. It means to say that going for the same drug may not be effective in those patients. So for those, we have defined guidelines. We call it as first line of therapy, second line of therapy, and third line of therapy. If there is a recurrence, then we say that patient failed the first line, he or she need to go for the second line. So the protocol is very clearly defined there, then I should follow those guidelines. So essentially what I am saying is that we need to have an adequate knowledge about the disease and also rational prescription. That's how we can overcome the resistance to any of the treatment.